and thank you all for coming tonight. We are thrilled to see all of you here. I'm Judy Regensteiner, Director of the Center for Women's Health Research, and we're here for our I guess, almost fall Let's Talk session, which is going to be on transitions, life transitions. We have a wonderful lineup tonight. The Center for Women's Health Research has the mission of doing cutting-edge research in women's health and sex differences. We focus on cardiovascular disease, diabetes, and now mental health as well. We have the second part of our mission is to mentor and train young MD and PhD scientists who wish to have careers in women's health and sex differences. We got to build that workforce so we have scientists who study women's health. So it's critical. The third part of our mission, and equally important, is to educate the public and their healthcare providers so that everyone knows the current guidelines for both women and men, and it's all evidence-based. That's the important thing to me, that everything be based on evidence, because only then will women and men both have optimal healthcare. So it's very important to us. So we have 3 speakers tonight, and before I start with that, I want to thank UC Health, who's been our longtime partner in this endeavor, and we really couldn't do this without UC Health, and we really appreciate that they partner with us, and they've been a wonderful partner. So our first speaker tonight, yes. I tend to blow through everything all at once, and that's probably not a good strategy for people hearing what you're saying, so sorry about that. So our first speaker is Dr. Neil Epperson, who's professor and chief of psychiatry at the University of Colorado, Anschutz Medical Campus. She received her medical degree from the University of North Carolina and then did residency and fellowship training at Yale. She was on then the faculty at UPenn, but we found her and we got her, and now she is ours, which is a wonderful thing. We got her here. Her career mission as a psychiatrist and physician scientist has been to promote the centrality of the brain with respect to all other areas of health, because nobody can do anything without their brain. Her work focuses on sex differences of the brain and the relationship with hormones. She is a highly successful researcher. She's been funded continuously for more than 20 years, and she's engaged now in not only continuing her very successful research program, but also building the psychiatric enterprise at our institution, which is an amazing thing to behold. So, Dr. Epperson.
Good evening, everyone. Thank you so much for giving that round of applause for UC Health for partnering with the Center for Women's Health Research to be able to produce this event tonight. But I want to give Judy and Nan and all of her colleagues and the staff at the Center for Women's Health Research a round of applause, for this is the 12th Let's Talk event. I mean, that's a lot of work. So thank you so much for all that you're doing. All right, so let's get moving here, because I have 30 minutes and I always have more to say than I can possibly get done. It's a pleasure to be here. I just want to say a few words about the Department of Psychiatry and the new program that we're developing, the Colorado Center for Women's Behavioral Health and Wellness. This is a lifespan program that provides behavioral health, psychiatric, psychological services to women across the entire lifespan. And it's a program that we're growing, and it will be really trying to meet the needs of women, not just only on the Front Range, but across the state of Colorado. So in any case, please stay tuned to hearing more about this program in the years to come. I've only been here, next week on Wednesday will be my first anniversary. So I've only been here a year, but we have a lot going on in the department. We're growing by leaps and bounds, and there's a lot of both clinical research and education opportunities for people in psychiatry, psychology, nursing, social work. Again, we're really thinking about building a workforce for this state, because we all know that access to mental health care, not just in the state of Colorado, but across our country, is really lacking. And we're doing what we can to promote access to care here in Colorado in the greater Rocky Mountain region. So currently we are housed in this building right in the back, the historic Fitzsimmons building. That's where we are right now. But with generous contributions from Mr. Phil Anschutz and the foundation. There will be a new building on campus called the Anschutz Health Sciences Building, and the whole Department of Psychiatry is going to be housed in this building. One of the things that really brought me to this region was the fact that there's so many people here that really get the importance of mental health. And you heard Judy just say that the Center for Women's Health Research is also now starting to focus on mental health, because again, without brain health, we can't have health. And there's plenty of data that shows that even if you have some other chronic medical condition, if you also have a comorbid psychiatric problem, so like you have depression or anxiety or PTSD or bipolar disorder and diabetes or cancer, that you don't get better with respect to the other medical condition if you don't also simultaneously treat the behavioral health condition. And so we're collaborating with the University of Colorado Hospital and Health System to really think about how can we get more integrated care into primary care settings so that we can provide behavioral health services at the right time with the right people and when you need it and in the area that you need it. So instead of having to go and find a psychiatrist or a psychologist, there would be one right there in your primary care practice. So again, a lot happening in this area. So I'll get off all of that and focus on the topic of today, and that is hormones in the brain. But before I do that, I always like to start with polling the audience. How many of you all, and it can be, you can raise your hand like this, but be bold, raise your hand really high. How many of you at some point in your life have actually asked yourself the question, I wonder if my hormones might be affecting how I feel? Okay, you know, most of you raised your hand, so my job is done. I don't need to tell you anymore. You all already know the answer to that question. Yes, the hormones are affecting how you feel. And I can go now, right, Judy? I'm done? No. No, the bottom line is that you're right. I'm glad you've asked yourself, because it only made sense to you. You know, it was kind of an organic thing that you had a thought to yourself, wow, maybe my hormones are actually having some impact on how I feel. Either my mood, whether I'm tired, whether I'm cranky, whether I'm, forgot that I already gave my kid lunch money and I was giving them more money, or I forgot where I left my car. I mean, people question across their life, do the hormones have effect on the brain? And the absolute answer to that question is yes, resoundingly yes, and we're going to talk about that here tonight. So, I'm going to start, because I'm a lifespan person, helping you understand how hormones affect the brain across your whole life. So we are talking about transitions tonight. Well, in utero life is a pretty big part of our transitions, right? That's where we develop. That's where our brain is developing. And basically, hormones have such a powerful effect even at the point of the late first trimester, first part of the second trimester. And what are those hormones doing? Well, guess what? Those hormones are doing what we call sexing the brain. Meaning, if you're an XX chromosome individual, you're born with a brain that is more sort of female, in the way you're going to behave in the future. If you are an XY chromosome individual, the hormones are affecting your brain in a way that you will demonstrate more masculine, or what we consider masculine type behaviors. Now, how does that happen? Well, the little baby boy has something called testicles. Those testicles, when they start developing, at some point during a gestation, they start producing testosterone. And everybody thinks of testosterone as a male hormone, right? Well, females also make testosterone, but in utero, the male is pouring out testosterone, and that testosterone gets converted to what we often consider more of a female hormone, and that's estrogen, right? Our ovaries make estrogen, our ovaries make progesterone. And so when we think about hormones for females, we often think of estrogen and progesterone because we make less testosterone than males. And when we think of males and hormones, we have a tendency to think about testosterone. Is that correct? I mean, would most of you agree with that? Okay, all right. Well, guess what? The male brain gets sexed in its maleness because testosterone gets converted to estrogen. That's one of the main ways in which you wind up getting a more masculine phenotype. So in utero, what we would consider later in life to be more of a female hormone, in utero, that hormone is actually having a very pronounced effect on the male behavior that we see later in life and what we call sexing the brain. So all these things that happen in utero, hormones have a powerful effect, okay? Whether you act more like a male or you act more like a female, it's really hormonally important. It's also being driven by these hormonal exposures, at least in part, by what happens in utero. So when we talk about sex differences, we're not talking about this particular kind of sex, but we're talking more about the fact that when you are born with a chromosomal complement, if you're XX chromosome, then you are considered a female, and usually your genitalia look like that of a female. And if you're XY, then you basically look more like a male. Now that's in 98% of the cases. Obviously, that doesn't always work out that way, and some babies are born with ambiguous genitalia, but by and large, this is the way it works, and we consider you male or female. Now, gender is a different thing, and we think about gender differently. Gender is often what we consider a social construct, sort of how people treat you. If you're a female and you're growing up in a very in a certain part, of the world where females are treated a certain way or certain expectations are of females, then that is the gender. That is how you behave. And so that's considered much more of a social construct, whereas males are expected often to be more of sort of like action, aggressive, rough and tumble. Again, that varies across the world. But we also know that there are changes in gender roles. And this guy says, hey, I'm the hunter. You're supposed to be the gatherer because as a hunter, I'm a male. I'm supposed to be the hunter. And she's like, well, hey, he was standing on the stuff I wanted to gather. So she clubbed the woolly mammoth to death. Well, that would be considered more masculine. Well, obviously, she needed to get to what she needed to get to, and she took matters into her own hands. We also know that in our society today that there are a lot of shifts in all of this, okay, and that there are different roles. And so we do see differences in how people are performing in the world with respect to what we consider gender norms. And so I'm not going to go into great detail about transgender or gender identity. That's going to be much more of our next speaker. But I wanted to bring it up because it is important when you start to think about health conditions and you start thinking particularly with how hormones affect the brain. So we know that there are sex differences in a number of different conditions, a lot of them with respect to the brain, but all other areas of physical health as well, and that they differ across the lifespan. You start to see sex differences in females with respect to depression, anxiety, risk for cognitive issues, particularly dementia later in life. Those sex differences tend to occur at the time of puberty. You start seeing an increase of about twofold increased risk of depression and anxiety in females. So there's something about the pubertal transition and these hormonal fluctuations that occur that seem to unmask the risk. For the males, you tend to see that there's an increased risk of ADHD, attention deficit disorder, autism, tic disorders, oppositional defiant disorders, and those seem to occur pre-pubertal. So we think that there's something about that hormonal exposure, at least in part, and it's not all about hormones, but in part, the hormonal exposure of sexing the male brain in utero that may be contributing to increased risk for these particular kinds of conditions in males versus females. Now, I'm just highlighting here that there's a plethora of medical conditions, not all of them having to do with the brain, that vary either in prevalence or severity or in treatment response or age of onset. In some way, shape, or form, there is a gender or sex difference. We typically, when we talk about biology, again, we're talking sex, and when we talk about social constructs, gender. But this is one of the reasons that the Center for Women's Health Research is so important, is because there are tons of these disorders that we study on this campus, that your doctors are treating, that show these sex differences. And we need to understand the role of sex and in a large part the hormonal changes that we experience and how they contribute to these risks for different disorders. So gonadal steroids vary, particularly in women across the lifespan. After puberty, you start to have periods and your hormone levels go up and down, estrogen and progesterone. During pregnancy, your brain is practically bathed in these hormones. I mean, it's like a bath up there because estrogen and progesterone increase somewhere between 10 and 100-fold during pregnancy. And then you have this, you deliver the placenta, and all of a sudden, all those hormones actually go away. And quite frankly, that's a major hurdle for the brain to have to jump, is to be able to manage dealing with all those hormones and then the complete withdrawal. Then at menopause, you have sort of these erratic hormonal changes, and we know that during these transitions, puberty, postpartum, perimenopause, that we see an increased risk for various types of behavioral health issues, but also people can have migraines that get exacerbated by their menstrual cycle. They can have improvement in their migraines even during pregnancy. Perimenopause can be a very difficult time for people with some medical conditions. Now, males, their hormones are a little bit more boring in my mind because they don't change a whole lot. After puberty, you get an increase in your androgens, your testosterone, and then all of a sudden, you know, it stays up high pretty much the rest of the male's life. Men can actually have enough testosterone on board that I think the oldest recorded age that a man fathered a child was about 92. Now, I wouldn't recommend it. Just because you can do it doesn't mean you should do it. But the bottom line is that it's a very different picture. We as females, the average age of being postmenopausal in America is 52. Okay, and we're going to talk a little bit about that when we get to the menopause transition. So let's talk just briefly about how hormones affect the brain. So I'm going to go through this slide very quickly. Estradiol has a pronounced effect on numerous neurotransmitter systems. Pretty much every neurochemical in the brain is modulated in some way, shape, or form by estradiol. These neurotransmitters, neurochemicals, are important for eating behavior, sexual behavior, the way you think. Can you think yourself out of a shoebox? Can you plan how to get from A to B? Mood, whether you are feeling good a particular day or particularly anxious. The bottom line is estrogen has an impact on those neurochemicals. So it's amazing to me that only about 20% of women at some point in their life have a depressive episode, because quite frankly, our brains are having to do these gymnastics and changing in response to these hormonal shifts all the time. Then we have something called nerve cells or neurons. And what I'm showing you here in the middle is a nerve cell that was taken from a very important part of the brain. This is taken from a part of the brain that helps you plan, helps you get through your day. It's what we call the dorsolateral prefrontal cortex. It's the executive part of our brain. And estradiol has an impact on neuronal structure on those nerve cells. At that really molecular level, estrogen is having an impact. Then we have impact on functioning of the brain, as well as how we behave. Progesterone is also very important because it has an impact on a part of the brain and a neurochemical in the brain called GABA. Now, why is GABA important? How many of you have a glass of wine pretty much on a regular basis? Or some glass of alcohol, okay? Well, you are modulating the GABA system when you are drinking alcohol. It causes you to feel more sedate and relaxed and what have you. Well, progesterone affects the same neurotransmitter system in a very similar way. So when you have high levels of progesterone during the menstrual cycle or pregnancy, if your brain did not adjust, you would be asleep through the entire pregnancy, because you would be basically having all of this progesterone on board. So it's a very important neurotransmitter and chemical hormone interaction that the brain has to adjust to over the hormonal cycles that we experience. There's also some impact on inflammation in the brain, and we know inflammation for the brain is not helpful. We also know that during pregnancy that it's not just about hormones, but it could be the fact that you've had adverse childhood experiences, you could have a lot of stress in pregnancy, you might be depressed during pregnancy. And so we know that that interacts with the hormones in pregnancy to program the offspring to either be resilient in their course of their life or to potentially also have risk factors as an adult. And so we know that this whole continuum of what happens here can have an impact in childhood as well as adulthood. So thinking about the transition to puberty, basically we said that there's increased onset of depression, anxiety, sensitivity to post-traumatic stress symptoms. That can all occur in women more so after puberty. And then we have something called premenstrual dysphoric disorder, which is actually a mood disorder that occurs right around the time that a woman gets her period, in the week to 2 weeks leading up to her period, where she has very negative mood symptoms that impact her daily living. This occurs in about 3 to 5% of reproductive aged women. That's a lot of women. That's millions of women worldwide that are suffering from premenstrual dysphoric disorder. And thank goodness we do have treatments for that. The traditional antidepressants that affect the serotonin system are particularly robust at helping those women. But we also know that birth control pills in these individuals can actually exacerbate their symptoms. And so basically we have to be careful as clinicians to make sure we understand whether women are having menstrual cycle related mood problems when we start to prescribe things like birth control pills. Then I want to say a few words about birth control, because one thing of my pet peeves is that over the history of the United States and the world, we have been doing a lot of hormonal manipulations of women's brains without really understanding how these hormonal manipulations affect the brain. Okay? Now, I'm not up here saying that I think birth control is a bad thing. I think birth control is fantastic. We must be able to have women control their reproduction. And there's a huge advancement in women's health and in women professionally, because they've been able to control their fertility. So birth control is incredibly important. My pet peeve is that the brain was not considered when we developed birth control. And basically birth control does not affect the brain the same way that natural cyclicity of ovarian hormones affects the brain. And we need to study that more. And it's very hard to get resources to study those kinds of questions. Now, let's think about the clinical ramifications. About 25% of high school girls, females, report being sexually active in a 2017 survey. That would mean that about 75,000 Coloradan females between the ages of 15 and 19 are sexually active. Only 10 to 30% of them, but that's still a lot, report the use of birth control pills currently while they're sexually active. Now, I'd like to see those numbers go up to 100%, because I think that children or young people or even people who don't want to get pregnant, that they have access to some kind of useful contraception. But the thing that this says to me is that there's a lot of young women that are using steroid contraception when we still don't really understand how it affects the brain. And there's data from a number of larger studies really causing us to have some concerns that there's a subset of young women who are going to experience a depressive episode after starting contraception. There's an increased risk of needing an antidepressant in the year after starting a contraception, particularly a steroid contraception. And there was also in this one study that was done, a large study done in Denmark, that there was an increase in suicidal thinking. Again, it wasn't a huge number of women. What we have to understand more is that if there's a subset, even if it's a subset of 1 million women worldwide, we should understand who is at risk and who is not, so that we can give them better preparations, or we can develop better preparations to help them control their reproduction, but at the same time not lead to depression. And I think a lot of these problems when it comes to not understanding how the brain is affected by these steroid contraception is because basically the brain is often the last organ system to be considered when people are trying to produce some kind of a treatment for some other problem. So you want to eradicate unintended pregnancy, give women the capacity to control their reproduction. That's great. But let's think about the brain while we're doing that. And that's really the only message that I want to get across with that. So what alters your mood has to alter your brain. So we know that certain types of progestins and various oral contraceptives are better or worse. And I think that we really need to call upon our pharmaceutical companies and our colleagues in industry to help think through which kinds of preparations are best. Because we do know that an unintended pregnancy is obviously not good for mental health. But again, we need to be thinking more responsibly about the type of products we're using. Now let me switch to the transition of pregnancy. Pregnancy is a completely unique hormonal state. Again, your brain is bathed in these really large levels of estrogen and progesterone. Basically, there's this precipitous drop in the postpartum period, and about 10 to 20% of women will experience postpartum depression. Now, how many of you knew that postpartum depression is actually the #1 or the most common complication of childbearing? It's not preeclampsia, it's not bleeding, it's not hemorrhage or infection. It's postpartum depression. And we've only just this year had FDA approval for a medication specifically for the treatment of postpartum depression. And guess what that preparation is? That preparation is actually a byproduct of progesterone. So progesterone gets converted to a steroid that is actually the drug that's being used to treat postpartum depression. Again, if our brains were not really flexible, and I love to talk about the female brain as being flexible, because if we weren't having this flexibility, we really would be asleep the whole time during pregnancy because we would be having these very high levels of progesterone. All right, menopause, very quickly. The hormonal state is highly variable. It's not surprising that people have increasing irritability, anxiety, mood fluctuations during the perimenopause. Again, the brain has to adapt to this new pattern of hormonal changes. The important thing to know that if you're a female child born in this generation, you're going to live a third of your life in the postmenopausal state. Now, the question is, should we live a third of our life without estrogen? Now, I'm not going to sit up here and tell you you should take estrogen. I'm just going to put the thought in your mind that maybe you should talk to your doctor about whether that is the best thing for you after the postmenopause. Because estrogen has profound effects on numerous body tissues. And we know that there's an increased risk of not only new onset depression, but if you've had a depressive episode before, when you go through the perimenopause, we know that you're again at increased risk of another episode. So if you've had depression, going through the perimenopause can certainly trigger another episode. But even if you've never had depression, there's still women that find themselves experiencing depression. A lot of people question whether the menopause is impacting their cognition. Well, cognitive aging affects us all, but an area of my research is really looking at the types of cognition that is improved with estrogen and for whom we need to be thinking about estrogen. And again, this is an area of ongoing research. We also know there's something called menopause, and that men who experience premature loss of testosterone can also have some fairly similar symptoms. They can feel fatigue, have weight gain. So hormones are also important in men, and I don't want you to come away from this without understanding that yes, androgens and testosterone in men is also really important, and that they can experience some difficulties. Then, of course, we've developed hormone therapy for postmenopausal women, but it was initially developed not with the benefit of the female brain in mind. It was initially developed because in the 1960s, it was a little bit paternalistic, this idea that somehow taking estrogen was going to make you want to have sex with your partner. And quite frankly, that's a little bit simplistic. Basically, hormone therapy was developed for libido and sexual functioning, at least initially, by a number of people who were writing about feminine forever. That is, one can have a sex life, but I would be more concerned about my brain and want to make sure that my brain is healthy. And that's, again, an area that we need to have more research, is understanding the effects on the brain. Basically, this is just saying, again, we need to have more research in this area, because dose does seem to matter when it comes to hormone therapy, and maybe Dr. Guest will talk a little bit about estrogen use in the peri and postmenopause. And I just want to have one last talk about another type of hormone, and that is the stress hormone, and the importance of stress in our life. Stress is ubiquitous, but it's also critical for survival. But there are ways that we can also manage our stress over the course of the lifespan. Our hormones also, and I don't have time to go into this, can exacerbate sometimes the effects of stress, but sometimes those hormones can protect us from the effects of stress. And the hormone estrogen can do that. The hormone oxytocin can do that. And how do we get shots of oxytocin? By having social interactions that are meaningful, coming together with friends and family. Exercise is also incredibly important for helping to protect the brain, even in the postmenopausal state. But there's also evidence to suggest that estrogen and exercise, you get sort of a double whammy. You get an extra benefit. So again, I always tell people, talk to your doctors as you go through perimenopause and postmenopause to see whether you're a candidate for hormone therapy. So I will take questions at the end. I need to leave it to Dr. Nokoff, who's going to be our next speaker. And I look forward to hearing your thoughts about this information and answering your questions. Thank you.
That was terrific, and we will have a panel at the very end where all three of our speakers will take questions, and there probably will be lots of questions. Before I introduce our next speaker, I just want to give a shout out to the advisory board of the Center for Women's Health Research. We have a lot of members of the advisory board here today or tonight, and our advisory board is woven into our fabric from the very start. It's all comprised of community members and who contribute enormously, and thank you all for coming tonight. That's wonderful, and we will applaud the advisory board. So our next speaker is Dr. Natalie Nokoff. And Dr. Nokoff is assistant professor in the section of pediatric endocrinology. She's also a physician. She sees kids. She got her medical degree at Brown University and did her residency and fellowship right here at our institution. Her clinical interests include caring for children who identify as transgender or gender fluid, as well as a wide variety of pediatric endocrinology conditions, including those affecting growth and puberty. Her research interests are primarily focused on outcomes of treatments for youth who identify as transgender. And come on up, Natalie.
Thank you all for coming tonight. It's an honor to be here, and thank you, Dr. Regensteiner, and the Center for Women's Health Research. They collectively support a lot of what I do, my research, and the work by others in our section. So tonight we're going to talk about puberty, a dynamic period of change. That was a really excellent introduction by Dr. Epperson that gave you some hints at what a dynamic time puberty is. So we're going to start by talking about what puberty is, and then when does it happen, what body changes take place. The question that comes up a lot is it happening earlier? What brain and emotional changes take place, which you heard a bit about, and how can I best support the teen in my life? How many people in the audience have a teen in their life, a kid, a grandkid, a niece, nephew, someone? Okay, excellent. So adolescence begins at the onset of puberty, and it describes a transitional time where the individual undergoes major changes in the psychological, social, emotional, and cognitive functioning over a period of years. I'll show you a bit of data that on average puberty is happening a bit earlier than it used to, and people are taking on adult roles later in life. So that is stretching the amount of time that people are in adolescence. And one might say that adolescence roughly lasts from about age 10 to about age 25 or so, because I'll show you that the brain undergoes massive changes throughout that period into your early 20s. So when does it happen? You got a hint of this from Dr. Epperson. Did you know that there are a few other puberties before the puberty that we think of in adolescence? So in fetal life, like you heard, the puberty hormones, or sex steroids, are at hugely high levels, and the signals from the brain to the gonads, meaning testes or ovaries, are as high as in postmenopausal women. So LH and FSH are those brain hormones that rise to dramatic levels in the menopausal period. They're equally as high in the fetus. Then you're born, and there are some rapid hormonal changes. There's actually a mini puberty of infancy that pretty much no one knows about unless you're a pediatric endocrinologist. So in both boys and girls, puberty hormones start to rise at just 1 week of age. And they peak at between 1 week and 3 months. And when I see young babies who I think will later on have issues with their puberty hormones, this is my window to see them in clinic and get some information. And it happens in both baby boys and baby girls, but it's shorter in baby boys. So in baby boys, the mini puberty lasts until about 6 to 9 months, and the testosterone is as high as in the middle of puberty or at the lower end of the adult male range. And in girls, these puberty hormones can actually last up to age 2, 3, sometimes even longer, and they're as high as in mid-puberty or an adult woman right after her menstrual period. And then this is an area of research that we don't completely understand, but the brain hormones are suppressed, and they're suppressed for many years. And at puberty, there's a release of that suppression. So when does it happen? For the average male individual in the United States, puberty starts at between 11.5 and 12. But there's a broad range, with the lower end of the normal range being 9 and the upper end of the normal range being 14. And here we're just talking about the start of puberty, not all of puberty. And in girls, on average, everything is 1 year earlier. So what changes take place? You heard about some of these hormones already. So up top is a part of your brain called the hypothalamus and pituitary gland. And these are the control centers for lots of functions in your body. And puberty is only one of them. And so at those average ages of onset, those brain hormones start to wake up, and they send signals to the gonads, typically testes in boys and ovaries in girls. And the testes grow in size and then start to produce testosterone. And you've heard that both men and women both make testosterone and estrogen, but in puberty the balance starts to shift. And that testosterone causes further genital growth, male pattern hair development, increase in muscle mass and strength, and a deep voice. And of course, this is also the time for reproductive maturity, and the sperm also develop. And in females, the ovaries produce estrogen and progesterone. Estrogen causes breast development, changes in body fat distribution in hips, and along with progesterone, the first menstrual period. And along with that, you get maturation of the eggs. Now, you probably realized I left a few things out, and that's the job of the adrenal gland. So the adrenal gland are these little pancake-sized glands that sit on top of your kidneys. You see them here, the yellow structures. They're also very complicated organs that have lots of different jobs. But one area of the outer portion of the adrenal gland makes cousins of testosterone that in both boys and girls cause body odor, underarm hair, pubic hair, and acne. And believe it or not, we don't really understand what turns this system on. You'd think we'd know that by now. But it's different than what I showed you here. These are separate but related systems. So what about the sequence of events? So on the bottom, you'll see age, and we're talking about puberty in girls at this point. And in blue lines are the average age of these things developing in African American girls, and in the red lines, Caucasian or white girls. And you can see that on average, changes take place in African American girls about a year earlier than Caucasian or white girls. And so here, initial breast development in the range of age 9 to 10, the first menstrual period in the range of 12 to 13. The peak growth spurt happens right before the first menstrual period, and puberty is generally complete by age 14. I think because so many people associate menarche with puberty, they don't realize that by the time that's happening, everything's almost done. And by the time you've had your period, you're also almost done growing. And we'll talk about growth in stature in a minute. For boys, less is known about puberty in general, actually, and racial and ethnic differences in timing. On average, you'll see in red, the testicular size starts to increase around 11.5 to 12, followed by the onset of pubic hair. Boys have a growth spurt later and longer than girls, and the growth spurt occurs closer to age 14. So I always think about 8th grade, all the 8th grade girls are this tall and the boys are this tall, and then you start high school and it changes. And boys come to see pediatric endocrinologists quite a bit around 14 if they haven't started puberty or they're not as tall as their classmates. And as you get older, you start to see more of the outward changes, including the strength spurt, development of facial hair. But puberty in boys isn't really done until about 17. The growth is also rapid in puberty, not as much as during fetal life or infancy, but it is still dramatic. So adolescents grow on average 3 to 4 inches per year, and girls stop growing at about 14 to 15, and boys later at 16. And how much you grow and how tall you end up really depends on your family, your genetics, but also how early or late you entered puberty. So for those early bloomers who started at 8 or 9, they'll have their growth spurt earlier, they'll finish growing earlier, so they'll be really tall 7th graders, but short high schoolers. And if you started late, you'll have your growth spurt later. These are those men that grow in college and end up a bit taller. So is it happening earlier? It kind of depends on what time span you take. But if you do a Google search, you'll see lots and lots of articles like these, is this the new normal? And before age 10, I already told you, is actually pretty normal. So if you grew up in Europe in the 19th century, you had your first menstrual period between 16 and 17. And then 100 years later, that dropped to about 13 years. In the United States in 1887, girls on average were having their period just shy of 15 years, and then that dropped to just under 13 years between 1950 to 1970. And you see this trend over and over in study after study that hygiene, nutrition, and socioeconomic stability greatly impact pubertal timing, and a lot of the earliness of it is just because we have better living conditions. If you look at puberty in developing countries, in more well-off parts of the country versus less well-off parts, you'll see the same thing. So in black are well-off areas of these countries, and the first menstrual period occurs between age 12 and 13. And in the underprivileged areas of these same countries or different countries, the first period occurs at a much older age, 13 to 16. There have been 9 large studies from the 1930s to the 2000s that have shown that the average age of breast development still is about 10 for Caucasian girls and closer to 9 for African American girls, and the average age of the first period is 12.5 to 13. You'd think that we'd be pretty good at these studies, but we're actually not. To actually assess puberty requires a careful exam by a trained professional, and to see changes over time would require thousands of exams by hundreds of professionals with repeated visits. So these are big, expensive, and challenging studies. They have been done well a few times. Women generally remember when their first menstrual period is, so we have better data in girls as compared to boys because most people recall generally how old they were when they started their period. And there's no such marker for boys. I know because I'm an endocrinologist, if you ask boys or men when they started puberty, you get blank looks. So same thing in studies. It's harder to assess. You don't have a big landmark like a first menstrual period. So there are fewer studies and less data. There have been 2 studies that have actually looked at testicular volume and pubic hair, and they've shown that the average genital or testicular development starts between 10 and 11, and underarm and pubic hair starts around age 11 to 12. And then one really creative study that I loved looked at adolescents seeking medical attention for acne as a proxy for puberty, and in boys in the United States saw an average decline of close to a year between the 70s to the 2000s. But there are other things that impact puberty. Weight impacts it quite a bit. This is an emerging area of research and one that many of my colleagues in pediatric endocrinology are trying to sort out. But the summary is that earlier maturing girls are relatively overweight and later maturing girls are relatively underweight. And people are trying to understand the hormones that change throughout puberty that cause people to go into puberty earlier, or hormones that change in obesity. So there have been several studies looking at this, and to sum them up, we know that in girls, obesity appears to be associated with earlier onset of breast development and an earlier first period. And in boys, the link between obesity and pubertal timing is less clear. And actually, one of my colleagues, Dr. Kelsey, and I wrote a paper recently showing that in boys, obesity may actually have the opposite effect and be associated with delayed puberty. So earlier in girls, later in boys, still a lot of research to be done. So what about the emotional changes that take place? I liked this quote from a research article saying the fundamental task of adolescence is to achieve adult levels of social competence. So here's what you might think would be going on in an adolescent's brain. I hope that you've learned from Dr. Epperson that it's a little more complicated than that. So here's your brain, and here are some scans of it. And this is not my area of expertise, but I am learning. So gray matter is kind of where the work of the brain is done. And that becomes less dense as the brain matures. And I put scissors up there because adolescence is a time of pruning of gray matter. And the gray matter is pruned out, and more connections are specialized and efficient during adolescence. And this pruning and these changes still are taking place in the early 20s. And there are a lot of changes taking place in the frontal lobe. The frontal lobe is responsible for problem solving, judgment, planning, inhibition of risky behavior, organization, attention, emotional control, and self-control, all things that you rightly might assume that adolescents are not particularly good at. And what's remarkable is that on imaging studies, you can actually see changes in the brain that parallel the improvements in cognitive abilities and emotional processing. There's improved abstract reasoning, attentional shifting, organization, decision-making, planning, and response inhibition and processing speed. During adolescence, thoughts become more abstract, logical, and idealistic. They're more capable of examining their own thoughts, others' thoughts, and what's not surprising is what others think about them. But that's a normal developmental process to learn what others might be thinking about you. But then peers have an important role in shaping adolescent development. And they're more likely to interpret and monitor the world around them. However, they're less likely to reason more poorly than adults when they're in the heat of passion, in the presence of peers, when it's on the spur of the moment, in unfamiliar situations, or when behavioral inhibition is required for good outcomes. But if you take these things away, they're getting pretty good at reasoning in other scenarios. I do want to talk about risk in adolescence a bit. You probably know that adolescents are risk takers, and this is a normal part of the development of the adolescent brain. You should also know that interestingly, although adolescents are more likely to take risks, because they haven't lived that long and they don't have as many real-world experiences, they're very poor at gauging risks. And they don't always underestimate risks. Sometimes they vastly overestimate them as well. I didn't show you it here, but there was a very interesting study of a graph showing actual risk of sexually transmitted infections and adolescents' perception of those risks, and they actually thought the risks were dramatically higher than they are, which may not be a bad thing, but just know that they're not always thinking risks are lower. So there are some big surveys throughout the US that show that over the last 10 years, adolescent risk-taking behavior is declining. Now that's probably a good thing, but I think a trade-off to consider are that over the same 10 years, depression and anxiety are also on the rise, and whether there might be a trade-off. And some of that trade-off might be more time spent on phones, more time on social media, less or fewer in-person interactions with peers, and fewer opportunities to actually take those risks if you're sitting at home on your smartphone rather than out with your friends. So you'll see a series of graphs. These are also all taken from the Youth Risk Behavior Surveillance System, which is a high school-based survey that the Centers for Disease Control publishes every year or so. On the bottom shows you the year 2007 to 2017, and on the y-axis shows you the percentage. And this is the percentage of high school students who have ever used illicit drugs over the last 10 years. And the rate has declined from about 23% to 16%. Similarly, as Dr. Epperson was showing you, the percentage of high school students who have ever had sex over that same year has declined by close to 10%. But you've probably seen in the news that depression and anxiety are on the rise. So over those same 10 years, these are the percent of high school students who've experienced periods of sadness or hopelessness. And in the red are all students, but you've also learned that there are very important sex differences in rates of mental illness. So the top line in blue are rates of sadness or hopelessness among teenage girls in the US, and the bottom line in green are teenage boys. Similarly, this is the percentage of high school students who seriously considered attempting suicide in the past year. And the top is girls, and the bottom is boys. And I did notice on one of your slides, but didn't include this data, the sex difference is actually opposite in those who complete suicide. So what can you do to support your teen? So firstly, listen. I don't yet have any teenagers. I have a 2- and a 3-year-old, and they feel like teenagers, so I'm preparing myself. But I do work with a lot of teens in clinic, and I've tried out different things, and I think some of these tips are things that really stick in clinic. So one is listen. Really listen. Don't interrupt. Don't stop to tell them your opinion. Just sit there quietly and listen to all they have to say. And they might actually talk if you keep your mouth shut. 2, validate their feelings. I've found this hugely beneficial in my own clinical practice. If you see someone who just had a breakup, or just was bullied at school, or just had a terrible interaction with a teacher or peer, don't say, oh, they probably didn't mean that. He wasn't right for you anyways. That's dismissive of their experience, and they're going to shut down, and they're not going to tell you anything anymore. So a better approach is to say, wow, that was really hard. That must have really sucked. I can't imagine how you must be feeling right now. And then tell me more. I think tell me is one of my absolute favorite phrases to use in all aspects of life because it's not very judgmental, doesn't assume anything, and it opens up the conversation for that young person or friend or colleague to tell you more about that situation. So you can say, wow, that must have really been terrible for you. Tell me more about what happened. And then they might start to talk. Show trust. This is really hard because people's instinct is to not trust teenagers, but they don't actually grow and develop and learn how to regulate their emotions and learn consequences for things unless they have some trust built in. So figure out what they can handle and task them with doing certain things that push the limits of your trust. Don't be a dictator. Set rules, but explain the reasoning behind the rules. Teenagers are now at a stage, unlike 2-year-olds, to actually understand the reasons behind the rules, not just the rules. And if they understand the reasons, they might be more likely to follow them. Fifth, give praise. We think about praising younger kids a lot. Teenagers tend to not hear as much praise as they would like. Remember to praise your teenager in your life. Control your own emotions. This is really hard. I have trouble with this with my own young kids. Remember, they literally cannot control their emotions. You can, because you made it through adolescence to achieve adult levels of social competence. So you are the bigger, better person to step away, take a few breaths, and go back and listen. And if you can't do that, just step away, because no one can reason when emotions are boiling. Do things together, and sometimes that might be talking, but other times it might be going on a walk, or a hike, or going to the movies, or activities where maybe you don't have to be talking, but that shows your teen that you care. Share regular meals, preferably without any electronic devices at those meals, and be observant. Lastly, being observant is also about noticing when these things might be creeping in adolescence that you need to notice, like the depression, anxiety, bullying, more serious medical or mental health issues. And I noticed you're not doing as many things now that you used to like to do. Is something going on? And then help that young person find help. And I didn't make these things up. I took them from people who do this research. So in summary, puberty does start at a pretty young age, around 10 and a half to 11 in girls, and a year later in boys. And if you really look back to the 1800s, it is actually occurring at a younger age, but in the last 100 years or so, it's leveled off. But there may be new impacts of obesity as obesity is on the rise. And those may be different in boys or girls. There are very complex changes in the body and brain during puberty. And although it's great that risk-taking behaviors are declining, depression and anxiety are on the rise. And finally, love, support, and listen to the teen in your life. I will briefly tell you about the research in our group, and then we'll end. Much of this is supported by the Center for Women's Health Research, and our group focuses a lot on women's health and sex differences. So this is our endocrinology research group over at Children's Hospital, and my colleagues and I study the risk of diabetes during the pubertal years, and there are differences in this risk between boys and girls, how sleep changes during puberty and how to improve sleep during puberty, puberty and sex chromosome differences, so boys with an extra X chromosome and girls with a missing X chromosome, complications in treatment of a very common problem during puberty, polycystic ovarian syndrome, and lastly, you heard briefly that my focus is on transgender youth. I think some of these resources will be posted on the website for you, and I'd like to thank you for your time.
That was really excellent, and I learned a lot from it, and it'll make me think when I'm talking to my own 25-year-old, but still, there are signs of the adolescence still there, but keeping my mouth shut would probably be the best thing I could do, but I don't always succeed in that. So our last speaker tonight is Dr. Marcia Guess. Dr. Guess received her medical degree from the University of California, Los Angeles, UCLA. School of Medicine, and did her residency in OBGYN there. She then trained at Yale and amazingly is double boarded in OBGYN and urology. So she's a urogynecologist, which is even more complex than either field alone, which is amazing. And she is trained also at Albert Einstein and then did some work training at Yale. And she was on the faculty at Yale as well, in both OBGYN and urology at the Yale School of Medicine. So we have an all Ivy League faculty tonight, but okay, that's okay. We can deal with it. Dr. Guess's research interests include increasing women's knowledge about pelvic floor conditions and understanding the pathophysiology of these conditions, particularly as they relate to childbirth, pregnancy, and sexual dysfunction. Thank you, Dr. Guess.
While she's getting this set up, I will say I did not organize this. I am a urogynecologist, and I know some people have to go to the bathroom. And it's okay to take a break during my talk to go to the girls' room because I treat these problems, and I know someone has to go. So I have appropriately titled my topic, Womenopause, because we are women, not men. So why not begin with what it's really about, women? So with that, I will begin. And what I like to talk about is reasons to change just your approach to life. And it's because negative expectations and beliefs about menopause and low self-esteem are associated with more problematic symptoms. Then I'd like to say the winning mantra. If the grass looks greener on the other side, stop staring, stop comparing, stop complaining, and start watering the grass you're standing on. It's that simple, ladies, okay? So let's figure this out. Let's figure out how to make womenopause a positive thing, unlike menopause, which is supposed to be the worst time of your life. So my talk is going to focus on defining menopause, reviewing the signs and symptoms, discussing evidence-based treatments, and then addressing risks, benefits, and limitations of the current therapies. So menopause simply means you're not having your period anymore. I had a patient recently, and I said, so you're in menopause? She said, oh, no, that's been a long time ago. That happened years ago. And I said, well, yeah, but once it happens, it's still menopause. You're still in menopause. And she just looked at me with a blank face, and I said, forget it. The bottom line, ladies, is you're not having your period, you're in menopause. Some people call it postmenopausal. Some people say you've undergone menopause. It's really semantics. Menopause is menopause. So there are many faces to menopause, and I'm really happy to see the wide age range within this room because I think it's very important because there's age-related menopause, which we've heard earlier, and the average age is around that 51 to 50-year-old mark. But we have to be careful. There are a lot of young women out there who experience menopause. You can have what we call premature ovarian failure, and that can kick in as early as 27 and 28-year-olds in some women. And these are young girls who can't have children because all of a sudden they stop having their periods and their organs stop functioning. And you have to be very careful because this can be very traumatic for people, and their experience is going to last longer than someone who has menopause at a later age. So again, we have to think of the positive things and try to build on these things to make this experience as positive as possible. We also have people who have experienced cancers, and chemotherapy can induce menopause in women. So there are women who are having normal cycles, and all of a sudden they undergo chemotherapy. Again, this can be at any age because it depends on what type of cancer you have. So again, not being in a room and sort of assuming that someone doesn't have the same experience as you can be quite embarrassing because there are sometimes younger women in this room who are having the exact same experiences as some people who are older in the room. And then risk-reducing salpingo-oophorectomies. That big word just means we take your ovaries out. There are women who have family histories of breast, ovarian, and uterine cancers, and they might find that they have genetic predispositions to developing cancers over time. So some people come in and ask us to remove their ovaries, or we may recommend that they have their ovaries removed so it decreases their risk of ovarian cancer. Again, this can happen at any age. So once again, I like to remove the myth that menopause, the average age for natural menopause is 51 to 52. But there are a lot of women who undergo menopause much earlier than that. So what are the signs and symptoms? They're vasomotor symptoms, they're musculoskeletal symptoms, their sexual function or dysfunction, their pelvic floor changes, and their mental changes, which you've already heard about. I'm going to focus on the other and just run us briefly through each of them. So vasomotor symptoms, some of you have already experienced, and as you can probably know, you feel very, very hot all the time, and it can come at any time. Sleeping is more commonly when it happens. People often report hot flashes at night, but it can happen during the day and pretty much anywhere you are, and it's sort of this overwhelming sense that you're feeling hot. And, we call them private summers. We have all kinds of names for them. But that feeling doesn't feel good no matter where you are. And it's hard to sort of escape grabbing like a sheet of paper or something and fanning yourself. But you're embarrassed. You don't want everyone to know that you're having your private summer. Don't worry. It happens to everyone who goes into menopause, or at least a lot of people. And at this point, who cares if you fan? It's not a big deal, ladies. Bone disease. I think importantly, you can increase your risk of bone loss and you can increase your risk of fracture. The terms that we typically use are osteopenia, which is thinning of the bones, and osteoporosis is when they become so thin that it can be pathologic and you're at really, really high risk for a fracture once you develop osteoporosis. And we try to look for ways to prevent that. Sexual function in menopause. I like this slide because what it shows is sort of how lucky lower animals are, right? Lower animals have two conditions to have normal sexual function: their hormone time and if the environment is safe and ready for them. For humans, we've got the culture, the social, the environment, the body ready, if his mother's nice, if his brother's cute, do you like his sister, do you want your kids to look like him? It's very interesting because hormones are only a small piece of that pie. And I have a lot of patients who will walk in and say, I need those hormones. I'm having a problem, with sexual function. And we sometimes have to take a step back because it's not the hormones that are causing that sexual dysfunction. So in some women, hormones can play a role, absolutely. You can have increased vaginal dryness and other things that contribute to sexual dysfunction, but it can also be a bigger picture. And so I don't always like to just blame the hormones in those situations. So cultural, as I mentioned, social, religious, the anatomy. When you have pelvic floor disorders, you're at increased for sexual dysfunction. If you have vascular problems, decreased blood flow to the organs. If you have neurological problems, if you have psychological problems, and then as I said before, one piece of that pie is hormones. So sometimes I laugh so hard the tears run down my leg. Some of you know this experience, and I may have made your tears just run down your legs, and I apologize if I did. That is called urinary incontinence. Urinary incontinence, pelvic organ prolapse are very common conditions in women. In fact, 1 in 4 women, or 25% of women, have a pelvic floor disorder. I like the fact that we heard earlier that 3 to 5% of adolescents have pubertal issues that we were describing. And in this case, it's 25% of women. So it's 1 in 4 women, but we still haven't gotten this conversation out of the starting gate. And I, because I do this for a living, love to get this conversation out of the starting gate. It is common. It's important to talk about. It's important as mothers to talk to your children about it because there is a family predisposition or familial predisposition to developing these problems. So if a mother has it, her child is more likely to have it. I have mothers who would say, I would never talk to my daughter, I'm too embarrassed. I have daughters who come in and say, I never talk to my mother, I'm too embarrassed. And they don't know they're both my patients. So I encourage you, talk to your friends, talk to your family, because these are common problems. Why is it important? Because it affects your quality of life. There's an increased risk of depression, a loss of self-esteem, you reduce sexual activity, anxiety, embarrassment, and decreased social interactions. People actually stop going out of the house because they're afraid they're going to leak and smell like urine or smell like feces or have a problem when they're outside of their house. The sad part about this is 80 to 90% of people can be successfully treated. And there are a lot of people out there who are suffering with these conditions and not coming in to see a provider and not being treated appropriately. So what is prolapse and what are we talking about when we're talking about prolapse? This is the normal pelvic floor. There are 3 holes down there for those of you who don't know. I know some of you don't. You don't have to tell your friend. Just keep it to yourself. But there are 3 holes. One is for the urinary system. So your urine comes out of this hole, and this is your bladder. This is the uterus where the baby sits, and the cervix where you get your pap smears. This is the vagina. The baby comes down this canal and through the vagina. And this is the rectum, and this is the anus. So when we talk about prolapse, one or all of the walls of the vagina can fall down. If the front wall falls down, we call it a cystocele. If the back wall or the wall of the rectum falls down, we call it a rectocele. The uterus itself can fall down, and that's called uterine prolapse. I get a lot of patients who say, well, I had a hysterectomy. How can I have prolapse? It's because it's not the uterus itself that's causing the prolapse. It's the connective tissue support of these organs. And if the connective tissue is damaged, the support structures are damaged, the organs fall down. So in the case of someone who's had their uterus out, the vagina itself invaginates and pushes back out of the body, and you call it vaginal vault prolapse. There's also a condition called overactive bladder. I kind of alluded to that when I started. Some of you have to run to the bathroom. Don't worry, I'm not paying attention. It's right out to the left. So with this condition, people feel the urge to go to the bathroom all the time. They're getting up hourly, feeling like they have to go to the bathroom. They often blame it on the fact, well, I drink a lot. Well, my friends do it too. I told you 1 in 4 women have this problem. They go to the bathroom usually about every 1 to 2 hours, and if they don't get there in time, sometimes they'll leak urine. They often are the same people who were bedwetting as children, and so I like to bring this up because it's not just an adult condition. Children who bedwet have overactive bladders. The muscle itself is spasming and causing them to feel like they have to go to the bathroom, and if they don't get there in time, they leak. And so children who bedwet late in life do not deserve to be reprimanded. It is a medical condition that can be treated appropriately by practitioners. And many people who have this condition, it's not limited to the day, so they're getting up at night, running to the bathroom multiple times. That becomes problematic because they can't function during the day. So depending on what you do for a living, it can actually truly impair your quality of life. So what can I do about these problems? You mentioned the bones, you mentioned sexual function, you mentioned that I can pee in my pants. Is there anything I can do to feel better about myself? Where is that green grass you were talking about? So there are lots of things you can do. First of all, we talk about improving your overall health. You cannot get 1 or 2 conditions better unless you yourself are committed to getting your whole body better. And that's number 1, acknowledging it. You have a problem. It is not a normal part of aging. These things happen and they can be problematic. Yes, everyone goes and has menopause, but not everyone has hot flashes. Not everyone has bone loss. And when you have bone loss, you can have problems such as fractures, which increase your morbidity and your mortality. So we need to acknowledge these problems and try to figure out how we can treat them. If you exercise, weight-bearing exercise improves osteopenia and osteoporosis. So you don't always have to take a medicine. I have a lot of people, I'm actually from Los Angeles. I lived on the East Coast where everyone wanted that pill. They'd walk in my office and I'm like, well, you can do physical therapy. And they'd stop talking, Dr. Guest, where's the pill? What can I do next? And so I love Colorado because as I've kind of migrated back west, I've learned that people don't necessarily want a pill. They do like these things like physical therapy, mindfulness, other things that can improve your quality of life without just taking a pill and adding to that long list of medications that you take. So exercise is one of those things. Getting good sleep, and we just heard earlier that some things can affect your sleep. So we have to be careful. If menopause is affecting your sleep, then you want to treat your menopause so that you can sleep better. Sometimes simple exercise and eating right can make menopausal sleep conditions improve. Sometimes they can't. The best recommendation that I have is get under the care of a provider and work with that provider and make sure that provider's on the same page as you with regards to what you're looking for. Because if they're on your page, they will identify strategies that work for you and not just strategies that are in general work for everyone. You want a healthy diet. If you stop smoking, it does affect prolapse as well. It damages connective tissue, and it makes the organs fall down more. So you're more likely to have prolapse and urinary incontinence if you're a smoker, in addition to all the other medical conditions you can develop. I have successfully stopped people from smoking as a urogynecologist because no one wants to pee in their pants, and no one wants to know that their uterus is at their knees. So I don't have to say things like, you might die when you're 99, you may develop COPD. All I have to say is, do you want to stop leaking? And they usually say, okay, where do I go? What's that hotline number? I'm ready to stop. I also think that stress is a big deal, and stress release is very important both for your whole body life as well as my urinary conditions. Overactive bladders worsened by it. Menopausal symptoms can be worsened by stress. And stress relief is really important. There are a lot of mindfulness things that are out there now that we really encourage. And there are a lot of people out there who can help you with stress reduction. I think there's a lot of looking inward as well. We tend to be, as women, multitaskers. I was like, she was talking about not screaming, and the other day the house seemed like it was in total chaos, and I'm yelling, and I'm like telling my husband like these 10,000 things that he's not helping with, and he just stops and says, I don't think we need to do 90% of those things. And I'm like, okay, we're clearly on the same page. And so then I take a step back and I realize that we do too much. And I think as women, sometimes it does cause us more stress. And do I have to mop the floor after the dinner party, or can it wait till tomorrow? Or can I call somebody and hire somebody to do that tomorrow, right? I feel like every little task that we feel like has to be done yesterday may have a role in giving it a better timeline so that we can reduce the stress from our lives. Once he said that, I did realize that some of the things, not 90%, I kind of met him in the middle, maybe 40%, right? It's going to be on my side. I could probably put off. However, some of these things do have to be done. So just trying to identify people who can help you do these things, get a priority list, figure out what you have to do now and what you can wait to do. And then communication. Communication with yourself, communication with others, recognizing how you can improve your life with the support of others is really important. So if you talk to people about what's going on, again, I do pelvic floor conditions that people don't talk about. I encourage them to talk about them. It's a weight off of your shoulders when you realize your friend is already being treated for that condition, and I never thought to ask her. She mentioned 1 in 4 women, and my goodness, it is very common, and I don't have to worry anymore because there are lots of people dealing with this. Remember that when you're dealing with these conditions. So what is mindfulness in menopause? Mindfulness has been shown to improve quality of life, it improves sleep quality, it reduces the severity of insomnia, it improves attention levels, and it reduces vasomotor symptoms. Everyone now is on the internet. There are some simple 2-minute mindfulness tasks that you can do, and I encourage everyone, even tonight before you go home, just go on the internet and put mindfulness, task 2 minutes before I go to bed. And there's lots of things you can do. Even there's one where you chew on a chocolate. You don't chew on it, actually. You actually suck on the chocolate, and you spend time thinking about that chocolate in your mouth. It's simple, it's easy, but it takes your mind off all the other things in the day that you feel are overwhelming you. And it gets rid of that overwhelming feeling and gives you a better quality of life in just 2 minutes. So I really encourage it. So also learning your triggers. Your triggers are the elephant in the room because they are things you have to control. They are your triggers, and you have to change your behavior usually to modify these triggers. If you've had negative prior experiences, abuse, pain, relationship discord, you may need to talk to someone and have that addressed, because it's always going to be a trigger unless you address it with someone who can help you identify ways to minimize that as being a trigger. Fatigue, again, overworked, multitasking. What can I do? Other people cannot do this for you. You have to figure out how to reduce your fatigue. Yes, there's lots of things that need to be done, but they need to be done now. Depression. Again, we heard a lot about depression earlier, and there are a lot of great professionals who can treat depression. It is rarely treated alone. So again, recognizing when you need help and if you need help, and seeking that care when necessary. Are your medications contributing to your problem? In some cases, they may be. Talk to that provider. Make sure you're addressing with them the symptoms you started having when you started that medication. Sexual anxiety. Are there cultural, social conflicts? Have you had abuse before? Have you had prior negative experience, a divorce, a bad relationship that may be contributing to these problems? Genital sensation. Is there a problem, MS, spinal cord injury? There are a lot of neurological problems that are very common today, and people are living longer with these problems and living healthier. So they still want a healthy sex life. So talk to people. If you have these medical conditions and you have a sexual problem, you can talk about those problems and they can easily be addressed. We've actually begun a multidisciplinary sexual health clinic here at the university, and we have great providers who can address these conditions with you and get you treated. Is your partner having sexual dysfunction? A lot of people stop having intimacy because of a partner. There's lots that we can do that can give you that intimacy even if you or your partner has some kind of dysfunction. And then vaginal scarring. Again, I deal with prolapse and incontinence. So these are pelvic floors that are not necessarily considered normal anatomically. We can still make these pelvic floors work for you. We just need to know what it is you are looking for your own personal quality of life. So what do we do to treat these problems? You can use systemic hormones for the hot flashes. It is the best therapy out there. And they come in pills, patches, gels, and now transdermal injections. What I tell people is your goal is to aim lowest and the shortest duration. That's the evidence-based. But most important too, I'm getting a lot of people coming in saying they're checking my hormones and I need 3% of that and 5% of that and it's gonna cost $1,000 a month. I think that's hogwash personally. I think you're spending a lot of money. You hear Judy here is running these research center, right? Let's get the research behind it before you delve into it and spend all that money. If you want to invest your money, invest it into programs like Judy's, the Center for Women's Health Research, because then we can study these things, we can save you money, and we can use the things that really work and not just things that people are telling you will make your hormones better. Cardiovascular disease, breast cancer, blood clots, and strokes have been reported with oral estrogens, but again, it's a balance. If you have history, if you have medical conditions that prevent you from taking that, you can talk to your provider about that. But many people are very safe histories and they can take these medications without problems. You can also take SSRIs or selective serotonin reuptake inhibitors, serotonin, norepinephrine reuptake inhibitors, gabapentin and clonopine specifically for hot flashes. Many people on gabapentin now, it's a great pain medication, so if you're taking that, you might notice that you're having fewer hot flashes. The downside of SSRIs is that they actually can increase your risk for sexual dysfunction. And so if you're balancing that as a problem that you've noticed with menopause, that might not be your go-to medication. Vaginal moisturizers and lubricants are different. Moisturizers like lotions are designed to be put on in the morning and they last for a really long period of time, versus lubricants are designed to be used at the time of an event. So if you're going to have sexual intimacy or intercourse, you'll use that lubricant, and then you use a moisturizer for more long-term treatment. And there's lots of moisturizers and there's lots of lubricants on the market. Again, I go with cost and making sure that you don't have a reaction to it because everybody's body is a little bit different. I am a urogynecologist, so I talk about things like sexuality, sexual function. I talk about the vagina falling out as if it's nothing. If some of you are concerned or don't feel like this is a topic you want to talk about, I am going to talk about some treatments for sexual dysfunction that may not make you comfortable. I am fine with people feeling like they may want to step out of the room. I like talking about it. I think it's important. I have a lot of patients who like talking about it, and I think it's an important topic to be discussed, but I like to just preface it with that, so if you go for the bathroom and don't come back, I will not be offended. All right? This is vaginal estrogens. There's creams, tablets, rings, and inserts. Again, there's some newer products. There's an estrogen antagonist agonist. There's DHEA. There's testosterone. There's many ways to get estrogen, and it's just based on whether or not you have any risks. I like to cite it with all of these are estrogen-like products. So if you've had a history of breast cancer, you're going to want to speak with your oncologist about whether or not these medications are safe for you. They do improve an overactive bladder. They do help with sexual function in women who have vaginal dryness. But again, you have to make sure this is the right therapy for you. Again, I talked before about antidepressants can harm your sexual function. So if you feel like you need it for hot flashes, you might want to try an alternate medication. These are some of the devices that I talked about. This is a device that brings vaginal blood flow to the vagina. It has been on the market for many, many years. You will rarely meet someone who uses it. I tell people it looks like a clapper. We can clap the lights on and off, and I think that's why most people don't use it. I think you need things that are palatable to most people so that they feel comfortable using these devices to improve their sexual function. Vaginal dilators are wonderful devices. If you have narrowing of your vagina from scarring, some people get it because of chemotherapy. Some people get it because they've had prolapse or incontinence surgeries. But if you have narrowing, you can actually stretch the vagina so that sexual function isn't so uncomfortable for you. They're online, they're on the market. You can get them very cheap. Again, just like estrogen, there's no one dilator that's a super dilator that you should spend $1,000 on. You can save your money and buy the cheapest ones because they all work. And the goal is just to stretch the vagina to be large enough and to bring blood flow to the vagina, because if you don't have blood flow there, the vagina won't work well. And then we did a study actually looking at vibrators. And again, I really am a promoter of women's health and comfortably talking about these topics. We did this study because vibrators are sold in sex shops, and we don't believe that they should be. So we studied vibrators, and we found that they increase blood flow and improve nerve function, in the vagina, and they improve sexual function. Now, Viagra is not in sex shops. It's a prescribed medication for sexual dysfunction. So why aren't vibrators? And so we feel that the more we study these things through research and the more we gain understanding on how they work and if they work, the less likely women have to go into a sex shop to get a treatment that actually works for them. These radio frequency lasers are now on the market as well, and people are describing them as the Mona Lisa touch and all of these things. There's not a lot of great data on them. I have had patients empirically say they felt better, but they're very expensive, and you have to continue the therapy to continue to get well. And people have described burns, scarring, pain during intercourse, and chronic pain as a result of it. So we do not recommend them, and we don't recommend anything without research. And more recently, the FDA made a statement saying that deceptive marketing of a dangerous procedure with no proven benefit, including to women who've been treated for cancer, is egregious. And I believe that. If you're getting these therapies and they're working for you, by all means, you may continue if you wish, but we really need research in this field. And again, this is what we do at the university. We try to research these things and understand if they're working and how they're working to improve your health. So again, with sexual intercourse, attempts at regular sexual activity are important because if you don't use it, you do lose it. I did an opinion piece in the San Francisco Chronicle in 2016. I feel strongly about these topics that no one wants to talk about, so how I ended with was communication really is key. If you think you're suffering, try to tell someone. If you think a loved one might be suffering, you might mention that you read about something called pelvic organ prolapse. Yes, in an essay about Deadpool. Deadpool is a survivor who can heal from any injury. Our patients are survivors too, but they need help with their healing. We need to start by rejecting the notion that some bodily fluids are a box office draw and others can't mention to even your closest family members. Thank you.
We're going to have questions for our panel now, and I have to say this was just an excellent presentation by all three speakers, and I really appreciate it. And I appreciate your coming tonight. The center is really proud of the research that we do and that we present evidence-based data to you. We do study people across the lifespan, starting in the womb and going to old age. And tonight we have one pediatrician and 2 adult docs, as we say. And please, let's have questions and answers. And thanks.
So you talked about the importance of estrogen and what I'm going to say hormone replacement therapy, but you didn't indicate for how long and to what age. Any insight into that?
So I think the concept of saying the shortest duration was because there's no absolute number for everyone, and it's based on symptoms. So if someone's symptomatic and they stop and they're still symptomatic, you're not going to say, well, suffer from your symptoms because we told you can only take your hormones for 3 years. There are many people who will transition early, so there's studies where they started women earlier and stopped earlier, and they found that they were able to transition over and not have as many symptoms over time. But that's not always the case. I've had people develop symptoms later. They never had symptoms, and all of a sudden they got symptoms, and they come in wanting some medication. We have a fantastic women's health reproductive endocrinology group here, and I usually encourage you meeting with one of the providers. My chairman, Annette Santoro, is like one of the gurus of hormones as well, and I encourage you to sort of reach out to those women because they really do try to tailor that hormonal therapy so that you're using it as little as possible, but not suffering because you stopped using it prematurely.
I've had a number of women refer to me over the years who went through premature menopause. So they went through menopause for some reason at the age of 40, and because their gynecologist had it in their mind from some source, well, I can only give this to somebody for 5 years. They would treat the woman between 40 and 45, and then they'd end up in my office having suffered for additional 2 or 3 years before really arguing to go back on the hormone therapy. So I would really support people not thinking about this as that one size fits all. I think if the Women's Health Initiative study showed us anything, and the data that have come out in the past 10 to 12 years, or actually it's more like 14 now, that one size doesn't fit all when it comes to hormone therapy. And that's why if you're going to your doctor and you're not getting the kind of information you think you need, I would agree with Dr. Guest that we have an amazing reproductive endocrinology and infertility program here where you can get excellent advice about hormone therapy that's individual for you. Not the what you were talking about before with the bioidentical where people pay thousands of dollars just to get their hormones tweaked a little bit, but real scientific based kind of information.
Yes, hello. I had this question for Dr. Epperson, right over here. I just had a curiosity about what you talked about, the brain being sex in prenatal life, and I just wondered, does that mean that the female brain doesn't get sex like the male brain?
What's interesting about that is that the default is, I like to refer to it, the default is female. If the little baby boys did not have exposure to testosterone and then conversion of testosterone to estrogen, then their brain would be more feminized. So the female brain actually, now women have high levels of estrogen during pregnancy, but the female brain is actually protected because the placenta can help to deactivate a lot of the maternal estrogen. So the female brain doesn't actually get exposed to those high levels of estrogen the way the male brain does. And again, I in some ways don't like to talk about this in such a dichotomous fashion because even if you're an XY chromosome individual, so male based upon your sex chromosomes, your brain can be exposed to either more or less of these hormones in utero. And there's even some evidence that if you're like a female twin and you're in the uterus with a male twin, some studies have actually shown that when you look at some markers of things that we consider more masculine behaviors, that even that female might exhibit in some ways more masculine behaviors. Again, usually in a laboratory setting where you're looking at these things. And so it's complex, and it is a continuum. It's not either or. So that's one of the things I want to just make clear is that we all know women and females who have more sort of what we consider more masculine behaviors as far as our culture is concerned in some ways, and in other ways they may exhibit more feminine behaviors. And so, again, these are complex issues. It's just that the male brain is exposed to more of those hormones in utero.
Can I sneak
On
in
average.
one more question? I just wanted to know, you said about postpartum depression, and was that in the U.S. or worldwide?
Actually, it's worldwide. The prevalence of postpartum depression does range somewhere between 10 and 20%. And again, when we say 10 to 20%, there's milder cases, and again, it's a continuum from milder cases that are somewhat self-limited to more severe cases where you really do need to get professional treatment. But it is across the globe, somewhere between 10 and 20%.
I have a question regarding sleeping. I'm just wondering if you have more advice about that. Like, I know about healthy nutrition. I'm a nutritionist myself, about mindfulness, about exercise. One of the doctors I met recently was talking about things like and I'm sorry, my French accent, but theanine or ashwagandha. I mean, they're like alternative medicine.
Are these
besides
herbal
just-
strategies are you talking about?
Yeah, I know. Theanine is more like, I don't know if it's a compound or, are you familiar with that at all? Or do you have any other advice besides taking, medicine that helps you sleep? And besides whatever I said earlier, there was more like, the obvious lifestyle
There is
changes.
some evidence that some people require less sleep. So I guess the question would be, are you not getting enough hours? Or you're not falling asleep when you want to fall asleep? So in some situations, you might have to find yourself going to bed earlier. People talk about the electronics, getting rid of the electronics because it keeps your brain working late at night. And also recognizing that perhaps you're someone who doesn't need as many sleep hours as someone else. So as long as you're getting the requisite number of sleep hours, it might be okay for you. I think you're doing the right things, that you're talking to providers about how to do this. If you don't feel like you're getting enough out of your primary care provider, I would recommend either seeking another primary care or having your primary care refer you to someone who may have a bit more expertise in this area.
I agree with that, and if you have questions about adolescence and sleep, then this is the lady to talk to.
I have adolescent, that's why I can't go to bed early anymore.
Well, I don't know that we can help you with that. One thing as a psychiatrist, I want to say that sleep is underrated as far as what we study. And it is very difficult to find somebody in mental health or in medicine in general who are really good at treating sleep. And as important as sleep is to our mental health, our cognitive functioning, our overall sense of well-being, I wish we had more research in sleep, and I wish we had better treatments for sleep problems. But the one thing that is very important is if you're having severe insomnia, there are even online something called CBTI, cognitive behavioral therapy for insomnia. There's something called shut-eye, which I know people who've had even severe insomnia who've done these online courses and trainings that have been able to help themselves really get better sleep because it's using methods of sleep consolidation. A lot of times we just lie in bed and toss and turn. So it really helps to teach you how to kind of consolidate your sleep so that you start to sleep better when you are in bed. So there are some things to do, but we do need more research and improving sleep. I think that there are genetic predispositions as well to not being able to sleep. There are a lot of things in our society with taking high school kids who really need to sleep and making them start school at like 7:15 in the morning and those kinds of things. I mean, we as a society do not respect sleep. We don't get it. We don't understand it. We do all these things. We give kids these tools to look at, and with these lights that keep us awake. We do it ourselves. I mean, truthfully, I actually go to bed and I use a regular book because I don't want to have the screen, stimulating me not to be able to sleep. We use caffeine. We use alcohol. I mean, truthfully, alcohol can help you fall asleep, but it's going to disrupt your REM sleep. And you're probably going to wake up 3.5 hours later after you've had one REM cycle. And so it's not good sleep. So if you're noticing that even having one glass of wine, you may only want to do that on the weekend when you don't have to go to work the next day.
Can I just say something about the CBTI that you mentioned? I work for Kaiser Permanente, and we have a number of CBTI classes that are available if anybody is connected with Kaiser. It's definitely recommended to do that with consultation or supervision rather than doing it online, so just to mention that. But it's a very well-studied program, and it's very effective, so I support that.
I think I was referring to the shut-eye because you're right, CBTI is usually done with a clinician, but shut-eye can be done even just online.
I have a question for Dr. Nokoff. Can you elaborate when you said hygiene, nutrition, and socioeconomic stability affect puberty?
That's more looking historically, like from the 1800s to now, improvements in overall living conditions. And when you look at ages of puberty onset in countries who are undergoing some of those same transitions now that the US and Europe were undergoing, from the 1800s to the 1900s. Not so much in terms of like, did you clean your house and did your teenager take a shower? This is really more, access to clean water and healthy food and not undernutrition. That wasn't meant to be anything personal if anybody took it that way. It's really societal. And I don't know that we completely understand all the ways that all of those things impact puberty, but we see those very clear trends across countries, across time.
I was wondering what your opinion might be on a lot of these Kegel weights that are often advertised. Kegel weights.
Great question. Kegel weights, they do work. They do work, and the electrical stimulators work as well. They're home-based physical therapy. What I tell people, to do the weight, you have to contract the pelvic floor, so you're almost doing a guaranteed Kegel. And Kegels and strengthening the pelvic floor can improve urinary incontinence and prevent progression of prolapse. So they absolutely do work. If you're putting them in and you're not able to hold them in, though, I would strongly recommend a physical therapist rather than believing you can't do it. I tell people a physical therapist is the personal trainer of the pelvic floor. When you go in that gym and you don't know how to use any of those machines, that's what the physical therapist teaches you how to do. They teach you how to build your pelvic floor muscles so that you can keep those weights in, get stronger, and prevent or reduce the pelvic floor symptoms.
Is it also therapy that you do basically for the rest of your life?
So I tell people that when you're strengthening a muscle, is there any muscle you don't have to strengthen for the rest of your life?
Makes sense.
Thank you.
That was a quick answer. There's a question.
Hello, my name is Vanessa. I am a youth leader at a church out in Thornton, and I work with a lot of kids that have depression and anxiety. Is there any website or references that you would have that we would be able to help children?
I think it's important to know that, these things are on the rise and that it's okay to talk about. When kids are in acute danger, there are certainly things like suicide hotlines and, things that I think anybody who works with youth in any situation should know about, where kids can call and get help or go right to an emergency room. And have a trusted adult, that might be you or someone else in church, having at least one trusted adult to be able to open up to or plan for their safety. As far as, websites or things like that, I think, that individual person wants to seek professional help so that they get the right type of therapy for them, or if they need medications, the right type for them. There's a lot of nuance around that. I can let Dr. Epperson speak. But I would say for emergencies, sort of big things are good, but for your day-to-day dealing with depression, anxiety, you really need individualized care.
No, I wouldn't add anything to that other than there are resources. I think it depends on where you live in the state. We do know that child psychiatrists and psychologists are rare, on the Western Slope.
I think when I moved here from Pennsylvania, I was told that like 85% of psychiatrists in the state either live in the Denver metro area or in Colorado Springs. So clearly there's a whole portion of the state where, even if you have healthcare insurance, it's hard to find somebody who treats children and adolescents. So there are a number of programs that are trying to develop more telepsychiatry. The Children's Hospital of Colorado, the department, our division of child psychiatry there does have telepsychiatry and telehealth. There are opportunities to come there to get treatment for kids, but one of the things that I think is really critical is if a kid is talking, even saying anything about suicide, we have to make sure that if they're talking to their friends, a lot of times friends will say, well, I just didn't think they were serious, or I didn't really. If a kid is saying it, they're serious, and it is a serious issue that needs to be addressed. It is not normal, even though I said stress is ubiquitous and stress is appropriate for survival of the species. We have to have stress in order to pay attention. The level of stress that some of our kids are experiencing today is not normal, and if they are talking at all about suicide, that is not normal, and it needs to be addressed right away.
Thank you.
This is a question for Dr. Knockoff. I was wondering what the concern you had or the allusion you made to hormones in the first years of life and transgender.
That's a good question. I'm not sure I was actually intending to make an allusion there. There are, if you want to talk about understudied areas, the mini-puberty is even less studied than any of these other hormonal times in your life. And I'm actually not aware of many other groups other than ours who are paying any attention to it at all. But when you're talking about hormonal programming of the brain, we talked about the mini-puberty and adolescence, it has to be important, otherwise we wouldn't do it. And there are certain conditions where you're not making enough of your puberty hormones so that you're missing those windows, perhaps fetal life, mini-puberty, and regular adolescent puberty. And mostly my colleagues that I work with study those. In terms of individuals who identify as transgender, there's even less that we know about hormones in the brain. We're starting to get a glimpse. One of my colleagues in another institution is starting to look at, across your whole genetic code, are there signals that we can see? There have been a couple of studies at the brain. Dr. Epperson's doing one in adults about, do brains look different in transgender individuals than when they receive a certain set of hormones? Are there further differences? But there's very little that we know. We certainly can't do a blood test or a brain imaging test and say, oh, aha, your gender identity is different than what we thought it might be.
One thing I want to say about just hormone use in general, and I think I tried to highlight it in the talk, that these hormones are important, and if you're gender dysphoric, we know, at least the data suggests, that using gender affirming hormone therapy can help your mood, at least acutely, at least help you to feel better acutely. Because I'm somebody who studies the brain, I'm concerned about long-term effects because, we've seen that we haven't really paid attention to long-term effects of steroid contraception. We haven't paid attention to, what dose even of hormone therapy in the postmenopausal woman is actually good for her brain, and does that vary from one person to the other? And now we're doing gender-affirming hormone therapy, which again, I think can be life-saving if you've got a suicidal teen or adolescent. And I know a lot of adults that have wanted to transition for 40 years and are so much happier once they have, even at the age of 60. And so I think we have to have these hormonal strategies because they're really important. But my point is that we still really need to understand their effect on the brain, not just acutely, but long term. And that's some of the work that we are trying to do here.
Hi, so I actually have two questions. My first question would be, have I have fraternal boy-girl twins that are 13, and they were born at 33 weeks. And I'm wondering if any research has been done on premature births and delayed onset of adolescence. They're late bloomers, I'm assuming?
Yeah, they're,
Yep.
I'd have to look into timing or how early a baby was born prematurely and onset of adolescence. I don't honestly know that off the top of my head. There are some clear associations with size of the baby regardless of whether they were term or preterm and future puberty. So we know that babies who are born very small, it's called SGA or small for gestational age, so that's usually less than the 5th percentile on the growth curve at the time of birth for their gestational age. Those babies are at increased risk of problems during puberty. So they tend to go into puberty a bit earlier. It tends to be very rapid, so they can lose their growth spurt. They end up a bit shorter. Some of those kids, that's actually a criteria for growth hormone. Not everybody needs that, but for some kids who are already very small and going to have a really rapid growth spurt and end up even smaller, some of those kids are eligible for growth hormone treatment. And can also be associated with problems with their metabolism later in life, like worse insulin resistance or risk of diabetes. So there's still a lot to learn about babies, how early they were born, their size, because that's fairly common. But I think it's more size related than age related.
Got it. Okay, so my second question is that I am currently in treatment for breast cancer here at UC Health. Sorry, I'm in treatment for breast cancer here at UC Health, and I'm currently in like chemically induced menopause at the age of 42 and facing an oophorectomy in October. So my question is, if estrogen isn't an option and you're staring at like half your life, menopausal, perimenopausal, I don't know all those words you were using, but like, are there additional risk factors and things that you need to be conscious of, or are there additional things that you can do to help yourself other than just generalized good health practices?
I think one of your biggest risks is your bone health, given the duration of menopause that you're going to experience. There are a number of non-hormonal based therapies, the bisphosphonates, that can help with bone health. So you're just going to want to stay on top of monitoring your bone health, which I'm certain your provider will do for you. I think that recognizing your risks, those weight-bearing exercises are key. If you haven't started them, you look pretty fit to me, but if you're not doing it with weight-bearing exercise, I strongly recommend starting some form of regular weight-bearing exercise. And I mean regular, like 3 to 5 times a week, because you may be able to prevent that bone loss that may be problematic for you. You're also at high risk for sexual dysfunction. And I don't like pointing at a single person. There's other people in this room, I'm sure, experiencing something similar. But my point being, your estrogen is going to decrease your hormonal level even more. The breast cancer, cancers have been associated with having sexual dysfunction because there's so much on your mind, and particularly female cancers, because it's that time when you're thinking about your female organs. And so, one, I think that, as I mentioned before, we do have a multidisciplinary sexual health clinic, and it really is designed for people who are a little more complex than simply, you know, I don't like his mother and I'm not having this experience, right? So I really, right. Exactly, and I think those things are very, very important. And there's also a lot of, as I mentioned before, vaginal lubricants and moisturizers. I have people who have family histories of breast cancer, and they don't want estrogens. You do not have to feel because you don't want estrogen, you can't have a good sex life and you have vaginal dryness and you're bothered by it. It is not true. You just have to find the right one, because there's so many. Some are sticky to some people, some don't work for some people, but I promise you, because I do it all the time, we often find something that works for everyone.
And I just want to give a shout out for the Sexual Health Clinic. One of the faculty members in the Department of Psychiatry, who is now the clinical director of our Women's Health Service line, is working. And so we will be actually having behavioral health and people who understand sexual health from that behavioral perspective also in the OBGYN or gynecology clinic. It wouldn't be OB, it would be the gynecology clinic, sorry. And I also work with a number of women who've undergone earlier menopause and experience things like cognitive issues and things like that, that we, there are other options. There's certainly, new treatments, new strategies to help deal with a number of different symptoms. And it's hard to know until you undergo the oophorectomy how it's going to affect you specifically. But again, I think one of the biggest messages that we have here is don't suffer in silence. Don't just think it's your burden to bear, that it's just something you have to tough it out. Really seek and talk to your providers and seek, options, because there are options out there.
Just for bone health in a menopausal woman?
So I don't treat menopausal women for bone health typically, but there are providers who do. There are a lot of non-hormonal options. I think, again, this is where you're looking at the big picture. Not everyone, although people will walk in saying, I'm here for my bone health, when you start asking the key questions, it's not often just your bone health. When you start asking, oh yes, and I have the vaginal dryness, or oh yes, and I've also noticed that I am having hot flushes. So I think that getting under a provider's care that you trust and working with them for what you're looking for and listening to them as to why they're offering these things would be very important. Our reproductive health group here is superior to most in the country, quite honestly. Nanette Santoro runs it, and she was already very well known nationally and internationally when she was on the East Coast, and she moved here to be the chairman of the department. And that our department really is great with taking patients like yourself who walk in the door and really getting a better picture of it. Is it just bone health, right? Because they have to ask a number of questions to find out things that you might not even know that may be also impacting you as a result of menopause. So I would recommend working with your provider and or getting transferred over to one of our providers to talk about that more in-depthly.
There's a question right there.
Yes, I have a question about the link between hormones and insulin uptake, because it just seems, for me, a constant battle with what is perceived as me being pre-diabetic when I do everything I think I'm supposed to be doing. And I don't want to take medications, but what is the link there?
There definitely is a link. I'll start by saying that. And I don't treat adult patients, so that's my caveat. But we know that both estrogen and testosterone have effects on the pancreas, both how it secretes insulin, and the effects are different in men and women. So estrogen sort of helps with insulin secretion from the pancreas. Testosterone, we think, can be harmful to that process in women, but it's different in men. So it gets very complicated because the experts on hormones and diabetes will tell you it's different at the pancreas compared to where insulin is working, like in your muscles or your liver or other tissues, and it's different for estrogens, testosterones, men and women. But you're not crazy, they do have effects, but they're very complicated effects, but they're real effects. Yeah, so if you're, I think it's helpful to see an endocrinologist who has expertise in the area of diabetes and hormone therapy, and there are several here if that's an option for you with insurance, and really go over what you see at different times with hormones, what it was like before, what it's like now. These things also change with aging and with time, so sometimes you might think, oh, it's definitely this, but maybe it's something else that was also happening at the same time that hormones were changing. But there are people that specialize in this area, and so if your doctor isn't someone that can really dive into that or has expertise, I'd recommend seeing someone else who does. Well, I think it probably depends on what your question is related to diabetes, but the endocrine group here, has certain people that are more focused on diabetes, certain people are more focused on hormone health.
That will be our last question.
No, I just wanted to put in a plug. Just listening to the questions that came out of this group, Judy, don't you think that we really should, have in our health system a navigator for women and the complexity of some of the issues that they're dealing with? So I would say talk to our hospital leaders and our medical school leaders, if you know any of them, and put a plug in for the importance of, I think really, again, women are the drivers of healthcare, not only for themselves, but for their families. And so you're like a CEO of your family's health and, thinking about your own health as well. And I think one of the things that we really do need and could benefit from is somebody who could understand some of these complexities of what you're bringing up and how to get to the right docs and which docs would be the appropriate people. So that's something I'd love to see here.
And this audience has very sophisticated questions also, so it's wonderful to hear all your interest in what research can find and can bring to you. So we're going to close for the evening. We'll be having another program. When, Nan, is our next one? November, we'll be having our next program, and we hope to see you all there. Have a good summer.